Hey everyone, my name is Jordan. I'm a nurse practitioner here with the hospital. I currently work in the cardiac intensive care unit. I've been a nurse practitioner for over 3 years now. I've had a lot of experience in my 10 years here at the hospital. I started out as a lift team technician who you may know they come around and help turn your patients. Worked through cardiac rehab as an exercise physiologist, then became a nurse in the CICU, and then just went back to school and became an NP, and here I stay. Um, I developed this class more so to help you. It originally started out more so as a critical care fellow class where I would teach them about our hemodynamics and how to use pulmonary artery catheters and the setup and the insertion. But that kind of changed. My focus changed more so to the nursing perspective because it's something that we didn't get in orientation, and it was more on the job training. Why is it important? Well, you were at the bedside, and so you need to know how these patients look, what some of these devices are, what these numbers mean, and what to expect in terms of when these patients are either A, getting worse, or B, getting better by medications and interventions we're doing. I apologize. This is an in-person class. I love teaching this class. It's a 2-hour, 2.5 hour long class where I just exhaust everybody. Um, and it's fun. I like seeing people's faces, their interactions, and just being able to answer questions. This is kind of the backup method. If I'm unable to attend the class or hold the class today it's scheduled. So again, I apologize I'm not there in person and that we're having to learn over, just virtually at this point. Just know, please, if you have questions or if you want to connect with me in terms of, Jordan, I just have a question about this specific thing you said in the lecture. I mean, email me. I'm in the CICU more so that I'm not. But I'm sure we can get contact information to you. But let's begin. So hemodynamics, it's a broad topic, right? So we cover everything in hemodynamics from heart rates on a heart monitor to non-invasive blood pressures. There is just endless information that we can cover regarding hemodynamics. What we're going to cover is definitely some anatomy and physiology in this lecture. It is also important that you know anatomy and physiology. I'm a big proprietor in saying, hey, if you know the physiology behind diseases or what medications do, you're going to be able to understand how you're treating your patients. A big part is medications we use to alter hemodynamics in patients. This is a very big one. We'll talk about pressors and inotropes, which are the two main classes, I would say. The equipment we use to gauge hemodynamics, we're not going to talk about like a heart monitor or a non-invasive blood pressure cuff or an arterial line because we all understand what they do. Our focus is going to be on the pulmonary artery catheter, and I focus on that because it gives us the most information. That is why I focus on it. There are other methods that we use to gauge hemodynamics, more so the flow track. That's a big one that we've introduced into the hospital, and you may have it on your unit. But we'll talk about numbers and what those numbers mean. I added shock states into this because it's important because no matter what intensive care we come into, you're going to be involved with a patient that develops some sort of shock. Whether that be distributive, not septic, because septic is distributive, hemorrhagic, hypovolemic, what may have you. Like, you're going to have a patient that's in shock. So we need to know what they look like. And most importantly, when we start medicines or we try to turn these patients around, what do we expect? That's the biggest take-home points. So talking about hemodynamics in general, so breaking down the word, hemo meaning blood, dynamics meaning emotion or a force. So it's basically blood forces if you were to put those two together. And then so we have the blood that's going throughout the body, and then we have structures and forces which either resist, inhibit this type of flow. Three things, or three terms rather, that in nursing school I know you probably heard of and that are very vital in understanding and kind of the building blocks for understanding hemodynamics are these. So you have blood that returns back to your right atrium, more so from your SVC and your IVC. That's called your preload, right? So the blood returning back to your heart. It's a good indicator of volume. We'll use that in terms of when we're looking at how volume up or volume down somebody is. We'll get that number, the CVP, central venous pressure. All that's looking at preload. We have arterial tone. So this is a big resistor of blood flow. Typically, we think about LV, or left ventricular arterial tone, or resistance. And we talk about that as in terms of SVR, systemic vascular resistance. And this is termed afterload. Think of it like a big old clamp on your aorta, where that left ventricle has to generate force to overcome that resistance. If that left ventricle does not overcome the resistance, or that afterload, you do not have cardiac output, okay? Because your LV is not able to push that blood against that resistance. Now, the LV is not the only place that there is resistance. You have a right side of your heart too, and that flows to your lungs. And so you have a pulmonary vascular resistance as well, and you get into a whole slew of problems if pulmonary vascular resistance is high. Think pulmonary hypertension. That RV is unable to squeeze blood forward into the lungs to be oxygenated, so you'd have a failing RV if that were to happen. These are both great examples of afterload. And then you have contractility, which is the overall musculature, physical kinetic energy of the heart. Now, you have someone with great contractility, like hopefully all of us have in this room. However, if you have someone that has a big old MI and they've knocked off a part of their heart, and let's say their ejection fraction is like 30%, and they don't have lateral wall movement, their contractility may not be as good. So think of contractility as the actual strength of the heart itself. I'm a big visual learner. I love putting pictures in my slideshows of talking about, hey, this is kind of what we talked about. This is how I learned in nursing school and in NP school. So again, I probably won't talk a lot on these slides. What I will highlight are the terms that we did talk about just now. The preload, where it's dumping into that right atrium. The afterload, there's that clamp you can think about. But remember, you also have right-sided afterload too, where the left side goes to your body, the right side goes to your lungs. So pulmonary vascular resistance being on the right side, and systemic vascular resistance being on the left. And then contractility is the actual kind of that burly looking heart himself. Let me see if my pointer works. Nope. There we go. The actual heart itself. He looks very healthy and very strong, where if you had someone that did not have a strong heart, it was more defunct, maybe one side or two sides or all sides didn't really work, and your contractility would suck. So why is this important? So, we talked about these big old components. They said, okay, Jordan, you've told me about preload, afterload, and contractility, but why does this make a hill of beans in hemodynamics? Well, it's all about the cardiac output. These three things are very important to determine what your cardiac output is, and it's very important to understand that when you alter one, you can alter your cardiac output of your patient. Here's the equation for cardiac output, which is just stroke volume times your heart rate. So again, cardiac output is the amount of liters of blood that is ejected from your heart per minute. The higher that is, well, simply put, the better it is, the lower it is, it's not great. Heart rate, I'm not going to explain because it's pretty simple. It's your heart rate. Stroke volume. Stroke volume is made up of multiple variables. And guess what they're made up of? They're made up of your preload, your afterload, and your contractility. So that's why I said if you were to alter one of these variables, you then shift and alter your stroke volume. You either, let's say you got a trauma patient and they've left more blood on the street than they do inside their body. So you've altered their preload here, which then alters your stroke volume, in turn alters your cardiac output. So it's a symbiotic relationship that all three of these variables are. The bread and butter of this lecture, I would say that a lot of people want to know, rather than the shock states, are talking more so about the medications we use to alter people's hemodynamics. The two big classes we're going to talk about are vasopressors and inotropes. Vasopressors, hopefully a lot of these look very similar, or not similar, but look very recognizable, especially this honking one right here, Levophed. I feel like everyone in the hospital, you sneeze, your big toe hurts, you cough, there's someone running to the Pyxis trying to override a bag of Levophed. Vasopressin, also a very common one. Epi, another common one. What is not common on here is this Giapreza, which we'll talk about. I honestly think that in the next lecture or two that I will remove this because I just don't think we use it as a hospital system anymore. Inotropes, the two big ones for me are dobutamine and milrinone. Dopamine and epi fall over on this list, and you can see that they do cross over. So just be very careful in terms of the look-alike, sound-alike medications, because you see you have dobutamine, dopamine. Don't be the nurse that goes to grab a bag of dopamine and then grabs a bag of dobutamine. You will have a very different outcome, and you'll be ridiculed. I'm just kidding. I hope not, but probably. But just familiarize yourself with these medicines, and we'll talk about, hey, what do these do at the different doses in a little bit. Some terminology we need to cover are more so talking about alpha and beta. So in this lecture, we'll talk about alpha receptors and beta receptors. So alpha, I want you to think of arterial. So it's more so affecting the smooth muscle on your arterial system or on your vascular system. So when I say a medicine, activates or increases alpha 1 or alpha, it means that it is stimulating that smooth muscle, causing constriction, and thus hopefully increasing blood pressure. Beta cells, so there's two different types. There's beta 1 and there's beta 2. Beta 1 is in relation to your heart, because beta 1, you have one heart, and beta 2 is more so focused on your lungs, because you have two lungs. In this case, we're going to talk about beta 1. Beta 1 and medications that affect beta 1 either stimulate the heart muscle to either A, increase heart rate, or B, increase myocardial squeeze, I'll call it, so increase contractility. Now, granted, you can also increase and decrease beta, but in most of these cases, we're going to cause an increase, either an increase in the heart rate or an increase in the strength of contraction. Continuing that train of thought, so on beta cells, I told you that, hey, we could increase or decrease timing, contractions, squeeze, whatever. So I just want to go over some more terminology with you. So chronotropy deals with the actual rate and timing, or someone's heart rate. You can remember this because Chronos is like some Greek god of time or something like that. Or realistically, we used to clock in and out on a time system entitled Chronos. So it is the timing of the heart. A positive chronotrope means we're going to speed up that heart rate, and a negative chronotrope means we're going to slow down that heart rate. A great example of medications that we give that really affect chronotropy are beta blockers. So we give someone some metoprolol, it's a negative chronotrope, so it slows down someone's heart rate. The absolute opposite, we have someone that we want to give epinephrine to, and it'll speed up their heart rate, so it causes positive chronotropy. Inotropy, this is a little bit more difficult to kind of say, well, how do I remember this? It's the actual strength or the condition of contraction that the heart muscle goes under. And I typically, see, this is why I like teaching in class, because I really get to make a fool out of myself. I want you to think of like an Italian grandmother that you've told a story to 100 times over, and she talks with her hands. And so she's making kind of this grasping motion, like she's tired of hearing this story over, and she's like, I know. And every time she says, I know, she's like squeezing her hand together. That's how I remembered inotropy. So we could think of a positive inotrope as something that stimulates the heart muscle to have a stronger contraction, and negative inotropy for something to have a weaker contraction. Another great example of something that's a negative inotrope is a beta blocker. There's a reason we give beta blocker in patients that have myocardial infarctions. A, it slows the heart rate down, and also causes a little bit weaker of a myocardial contraction, because it's all about conserving oxygen. That's the big key point with someone that has a heart attack, is conserve oxygen. And what a better way to do that than just say, don't beat as fast and don't squeeze as hard. And that's how we do it. So Levophed is it's probably our most commonly used pressor here at the hospital. It's a very old drug. It's a great drug. Did you know you make your own Levophed? You make your own norepinephrine. We make a lot of these drugs in our kidneys. I will stand on this. If you ever want to advance your knowledge, follow a nephrologist. Nephrology is more than likely the smartest discipline we have in the hospital. That's just my little ploy towards nephrologists. But Levophed had this stigma when it was first introduced and first used in the hospitals. And I remember my nursing instructor talk about, oh, they're on Levophed, they're dead. You better call the priest or somebody. Like, go ahead and call the funeral home because they're not gonna make it. And the Levophed, leave them dead mantra came out, and it was really concerning because it's like, why do we talk about this for a medicine that's used so frequently here in the intensive care units? And doing some research, it was actually brought on during the sepsis campaign, where grandma was placed on astronomical amounts of Levophed for her distributive shock. And if you know anything pathophysiological about distributive shock, is you lose vasomotor tone during the severe stages of sepsis. Thus, you have decreased venous return to your right atrium. Thus, you have decreased cardiac output. So grandma was just getting her blood vessels squeezed to death, and there wasn't anything to squeeze inside the blood vessels. That's why volume resuscitation is important in distributive shock. Now, granted, it's important. It's also important to know that you don't give people 16 liters of fluid. There is a diminishing return on how much you give them, and you support them after that with vasopressors, aka Levophed. Now, I do have medicine dosing on here, which is the mics per minute, and then you have the mics per kg per minute. I dubbed the surgery bro dosing. I do not live in the world of surgery, so I will, and I won't read out the dose ranges. You can read just for yourself. But what I will talk about is, hey, like there is a diminishing return on the, what a dose of Levophed can do. There are hard maxes, well, not hard maxes. They're soft maxes. 2 to 30 is what we typically say. However, there's new data to support that. We look at people's weights to determine what that mic per minute max may be. So if you're a 100 kilogram patient, the new data shows that, hey, let's make it synonymous with your weight. So 100 kilograms, well, 100 mics of Levophed should be your max. We talk about maxes in drugs because, hey, yeah, you can crank up this drug all you want and you can make a number better, but in the end, what are we doing? And that's what you kind of have to understand as a nurse, is just because you increase a drug to make a number better, have the conversation with providers and be like, what are we doing? Like, why are we increasing this drug? Why are we on 200 of Levophed, which has happened, by the way, just to make a MAP number look better? So let's talk about the effects of it. So at low doses of Levophed, you can have an increased heart rate, meaning you increase your chronotropy, or the beta-1 effects kick in. However, the primary effects that we want from Levophed are those alpha effects, which happen across the continuum of dosing. Vasopressin is another great drug that we use here in the hospital. It's a common drug, again, also made by your kidneys. It's synthetic antidiuretic hormone. You make this in your kidneys. A lot of people inhibit it from a weekend activity, drinking. That's what makes them pee. People talk about, oh, when I drink, I have to pee. It's like, well, you've inhibited antidiuretic hormone. That's why you pee. Alcohol does that. And so what it does is it promotes reabsorption of fluid in your kidneys, and it causes some vasoconstriction and adds some vasomotor tone, which in turn gives you more blood pressure. The most important part about vasopressin is its pulmonary vasculature sparing, meaning that it does not really cause vasoconstriction inside your pulmonary vasculature. Take, for example, you have someone with terrible pulmonary hypertension, and you want to try to reduce the amount of pulmonary vascular resistance or pulmonary afterload that right heart has to pump out against. But they're hypotensive on the systemic side. So we need to start a drug to help them maintain actual perfusing pressure, but we don't want to shoot ourselves in the foot. So we'll choose vasopressin because it'll help with systemic blood pressure while also not causing an increase of resistance on our pulmonary vascular beds. Our dosing ranges are below. Our hospital uses a new dosing range of 0.03, which is the kind of the standard, and that's just because there was no difference. There's no difference in 0.03 and 0.04 in terms of effect of this drug. There was actually a study that showed that, and it saved money. And you ought to know that anything that saves money, we're going to take part in. Epinephrine, what you may call it, whatever. It's a great vasopressor and an inotrope. So again, it crosses those boundaries of things it does. It is not ideal to keep someone on epinephrine though. Yes, you have patients in the cardiovascular ICU that are on epinephrine. Well, you would be too if you just had your heart cut into and things sewn to it. The heart needs a minute to recover. Give it a minute. It's there to help it, remember how to do its job. However, those nurses wean epi kind of quickly because it's not a great drug to be on for long term. Again, it has very strong alpha and beta responses, meaning it's going to cause vasoconstriction, increase your heart rate, and increase contractility of your heart. The dose ranges are there below. However, I do propose the solution or the situation though, if you have someone that is in cardiogenic shock, meaning that their heart muscle is damaged or is getting damaged or is weak, is it a good thing to keep someone or start someone on epinephrine? The answer is no, because in cardiogenic shock, you want to try to conserve the muscle. You want to try to, cause as much preservation of oxygen. You want to cause as less stress on the muscle as possible. And this is where I enjoy teaching in person, because you get to see how unhinged I am teaching a lecture. This is where I start kicking a podium, and where my foot is the epi and then the podium is the heart itself. I just kick the crap out of this podium and I'm telling it to beat, because that's what I'm doing as epinephrine. And a heart is not going to heal if you're just stimulating the muscle and you're essentially just flogging it to death. It's just not going to heal, and it's not going to get better. In fact, it's probably going to get worse. But that is my little spiel on cardiogenic shock and epi. Phenylephrine, Neo, this is not a drug that I'll take that back. I prescribed it once. I've done it as a Hail Mary to get family in here. This drug is all alpha. It is strictly used in surgery. That is a big use for it. It's actually used more prominently by CRNAs who carry it in their neat little drug kits and their little syringes. But you'll see people come up from the OR on like a bag of epi. It is potent alpha constriction. It's very good. It has very short half-life. So someone that gets a little sleepy and gets a little hypotensive due to anesthetic gas, they'll throw some phenylephrine on there and they'll say, all right, we'll call it a day. It's also found in Afrin. It's one of the main ingredients there. It causes vasoconstriction, stops some nosebleeds. It's very great for nosebleeds. You squirt it up there and then the nosebleed stops. Also stops congestion. It's one of the drugs that it has a very wide dose range, and you go up very quickly in the amounts that you titrate by. Again, not a drug that I'm going to use a lot in medicine, because I deal primarily with heart failure, and one thing heart failure hates is high afterload, and all this is increasing your afterload. I do joke that you get a call from the OR, and let's say you're SICU and you get a call from the OR and you're getting this trauma, and they've been volume resuscitated, they're a little hypotensive, and the CRNA calls you and they're like, oh yeah, their blood pressure, it's 140 over this, and you're like, oh cool, send them up. And so they're in the elevator, and then the CRNA sees their blood pressure dip to 70 over 30, where they're going to give a little bump of Neo, and then you'll get up into the bedside and you'll say, oh, how was, everything's still okay? And the CRNA is just going to chuckle and say, oh, yep, everything's fine, everything's good. You hook them up to the monitor, and now their blood pressure is 60 over dead. And as the CRNA is walking to the elevator, counting their $100 bills. Again, very prominent surgery drug, a great drug, but a drug that I'm not going to use a lot in medicine. Giapreza is a drug that the hospital did use a couple of years ago. It's a synthetic angiotensin 2. It's a naturally occurring peptide hormone in your body. It's a potent vasoconstrictor. Angiotensin 2 is a potent vasoconstrictor. We have angiotensin 1, who is a very potent vasodilator. And you can remember that, hey, we give medicines called ACE inhibitors to prevent angiotensin 1, which has those vasodilatory effects, from being converted to angiotensin 2, which has those vasoconstrictive components. So the ACE inhibitor blocks the transition from 1 to 2. Thus, we have people that live with normal blood pressures. These medications or this medication rather, was used primarily in our neuroscience ICU. That's where it was introduced. It did have success, I will say that. However, it was very expensive, and then I think the occurrence of thromboembolism were just through the roof. You could see that the dose is starting in nanograms, where everything else is either mic or milligrams. This was nanograms, and it was very particular on how you up titrated this medication. Pharmacists would freak out because you had to ensure people were on some sort of DVT prophylaxis. Unfortunately, if you had someone that was just bleeding, they didn't have any platelets, this was not a great drug, because they were going to find some way to clot, whether that be in their lung, their leg, their head, their finger. I don't care. They were going to clot somewhere, but don't worry, the map was pristine. They just had all these clots all over their body, but we just used a $60,000 drug to make that number there. Again, not utilized much anymore, and I think it's one of the drugs that I'm going to take out of this presentation. But you may travel somewhere different than ECU Health that uses Giapreza, and so it's also good just to know what these drugs are, and because it is out there. Dopamine, it's an old drug. It's probably one of the oldest drugs on this PowerPoint. It's also a vasopressor and an inotrope, depending on what dose you use. The lower doses will cause an increase in the amount of beta activation, meaning it'll increase and stimulate heart rate. The higher doses, you get more of that alpha vasoconstrictive properties of it. I typically use dopamine when I have sweet little old Meemaw who comes in. She's got a little low heart rate because she's taken her beta blocker that she's taken for 50 years, and those poor kidneys just don't clear it like they used to. She's a little symptomatic. She's bradycardic. So we throw her on some dopamine to see if we can bridge her to allow A, the medicine to wash out, or B, has she just completely screwed up her electrical system and she needs a pacemaker. Cardiac surgery will use 3 of dopamine. It's more so, that's dubbed the renal dose dopamine. Through my studies and through research, it has shown that it doesn't really work. It's more so just medical dogma. It's more so to promote blood flow through the kidney and recovery after coming off the pump. Again, it's one of those things that have been studied, and it's shown that renal dose dopamine is not a thing. It's a thing that's been passed down from daddy surgeon to baby surgeon, and that's just how it continues. And it doesn't hurt somebody. I think that's the biggest thing to put out there. Again, at the bottom, you can see those beta doses, or those lower doses of dopamine, and then those higher doses of dopamine. Granted, just know that whenever you increase someone to like 10 mics, their heart rate's still going to be elevated. So it's not like you get to the 10 mics per kg per minute of dopamine and then the heart rate is spared and you just get all alpha. You get a little bit of both. So this is honestly one of the drugs that you may see. Dobutamine. Dobutamine is one of my favorite drugs. It is my quick-acting inotrope, so it's going to increase the contractility of someone's heart. I use this a lot with patients that come in with decompensated heart failure, or if they're in cardiogenic shock. The dose range, again, is below. I have never used a dose over 7.5. I've seen people come in on titratable dobutamine as high as 10 and 20 mics per kg per minute, which is a terrible idea. That should never happen. What they're trying to do is target a blood pressure with dobutamine, which should never be in the titration parameters for it. Just to kind of let you know, if you see dobutamine as a blood pressure titration, please talk to your provider. The big problem with dobutamine is it is very arrhythmogenic. You have someone with an ischemic cardiomyopathy who has, decompensated heart failure and, they need some extra squeeze, well, we're going to put them on an inotrope. It's kind of a double-edged sword because you're going to cause more oxygen demand for the heart for their poor little ischemic heart. So you can have arrhythmias. One of the biggest ones we see is we have patients that flip over into AFib. Sometimes we'll see people that have non-sustained VT. The best way to combat that is to decide to change your inotrope to a more stable one like milrinone. You can give them antiarrhythmics. Excuse me. Or you can try to decrease the dose. However, it's a necessary evil though if you have someone whose heart squeeze sucks and you need them on some sort of inotrope, because if you don't, they die. But just know that you can see tachyarrhythmias from an inotrope. Be mindful, this is just my little ploy out there, that if you have someone that is in these decompensated states and we make a medicine change, please follow up with that. So if, I don't care if your vital signs or if you're supposed to get like SWAN numbers or device numbers every 4 hours. If you're making changes on medicines, be the good nurse, be the good critical care nurse that's going to say, I'm going to be more proactive so I can report either negative or overzealous changes in my patient. Believe it or not, you are able to advocate and you're able to report these things at an increased frequency. Have a conversation. It's one of those things where if I had a nurse and they're like, hey, do you mind if I shoot an extra set of SWAN numbers? I'm going to say no, because again, more information for this critical patient is better. Another one of the inotropes that we use, this is the more stable one, it's called milrinone. The problem with milrinone is once I start it, it takes approximately 4 hours for it to reach that steady dose state, meaning that if I set someone's milrinone at 0.2, it takes it 4 hours to marinate in someone's body for it to reach that concentration within the bloodstream. Again, don't see as many tachyarrhythmias with milrinone. It is possible, but it's just less prevalent than dobutamine. Again, this medicine can cause some hypotension. It does have a little bit more arterial dilation than dobutamine does, so it's just something that you should watch out for. This medicine was the go-to for patients that have heart failure and they were going home on inotropes. And it was either their destination therapy, meaning that they were going to live the rest of their life on an infusion, or it was just buying them time until they could get an LVAD or a heart transplant. The problem with this is we lost that coverage here in North Carolina, and it was because of insurance, which is the root of all medicine problems, I would have to say. And it wasn't because they took the milrinone away. They took the resources away where you would have these nurses that would go into the homes and troubleshoot these pumps for people, train people. They just lost that payer source. So now there's fewer companies with even fewer nurses. So it's just hard and or now impossible to find an insurance that will cover, or a home agency that will cover home milrinone and home infusions for this, which was a very big loss for our region. So looking at some of the devices that we can use to obtain hemodynamic data. Again, I told you earlier that heart rate is one, non-invasive blood pressure is another, but that's just something that we're not going to cover because they're just too simple, because we know what it tells us. Central venous lines, they're very important, and they're able to tell us a vital piece of information. They're able to tell us someone's preload. We're able to gauge information about someone's CVP, central venous pressure, which preload is synonymous with. Now, I will say it is only a valid measurement whenever it's done within the IJ or the subclavian. There's been times where people have done central venous pressures of someone in the groin, and I just have to question why, because it's so far away from your actual heart, where that measurement comes from. Arterial lines, obviously we all know what an arterial line and what it tells us. The pulmonary artery catheter, which is here, is the one that I am the most familiar with, and the one that I'm saying that if we're doing invasive things to patients in the sake of obtaining advanced hemodynamic numbers or data, this is the one that I'm going to go for. I've said let's just go ahead and put a SWAN in them. It's the most invasive, but it also gives us the most information. FlowTrack is another device that we've started using here at the hospital. Again, introduced in the neuroscience ICU. It's a pseudo swan is what I'll call it. It gives us some of this information, but not every bit of it. It's more reliant on the calculation portions because of the central venous and the arterial pressures. It does some like voodoo math and spits out some numbers. There are other devices here. From this one, I don't even know. It's a wrist cuff and it looks like a finger probe, and it spits out some information about a cardiac output and index. I am skeptical, but there are things that exist out there that we are using to get this information on people. Again, the most invasive, most information comes from your pulmonary artery catheter, which the cardiac units use very much. I do know that the MICU is putting in more. SICU will put some in. In the neuroscience ICU, I do believe they still use the FlowTrack predominantly. The gold standard of obtaining these numbers, especially intracardiac pressures, is still the pulmonary artery catheter. So still talking about this guy up here. In terms of heart failure patients, because you know this, if you've ever seen a swan, it's just a gaggle of cords, of tubes, of pressure bags, of whatnot. It's a nightmare to have to untangle and get your patient back up and down if they're mobile. Heart failure patients, to keep them out of the hospital, because that's the goal, right, is to keep patients out of the hospital. We developed this technology called the cardiac MEMS device. Here it says newer. It's not really new anymore. It's just technology at this point. It's about the size of a dime, and it goes in someone's pulmonary artery. And what this does is the heart failure patient goes home. They sit on their little tuffet pillow, and it transmits data to their cardiologist. And they're able to get some information, mostly CVP and their volume status. And they're able to say, hey, like, Mr. Jones, you've had a very salty weekend and your volume's up. Let's take extra Lasix today, and in terms to get some of this volume off, and hopefully get you back to a normal operating status. Again, it's all to keep these patients out of the hospital. So why is advanced hemodynamics, especially the numbers they give us, important? Well, it gives us a lot of information about patients. So it's able to help me discern, hey, how can I better change medicines on patients that come in with acute heart failure, or if they're chronic heart failure with an acute exacerbation, how can I manage them better? If a patient comes in with a huge myocardial infarction and they have mechanical support, you should always have these devices in place, because it also tells us how much support patients are getting from the device versus their heart's native function, and how much recovery we're getting. If we're having trouble differentiating shock, distributive shock and cardiogenic shock, if we just don't know what profile the patient's in, let's put a swan in and get some information. Let us see their output and index, and more importantly, their SVR. That tells us all we need to know about what shock this patient's in. Post-surgical monitoring, again, the CVICU friends, you've had someone with their heart cut open into, they're going to have a swan, because, again, they got drugs they got to titrate down, hopefully as this heart muscle recovers. Cardiomyopathies is another big one. Pulmonary hypertension. So patients that get started on pulmonary hypertension meds, sildenafil, and anything subcutaneous, they're going to want to see the PA numbers, or especially the PA systolic, because that's the number that deals more with that right ventricular systolic function. They're going to want to see the trend of that. And then, of course, transplant. Transplant cases are a little iffy now, because insurance has okayed them to get the information via a right heart cath. So it would be where these patients would have to come in, sit in the intensive care unit for 3 to 5 days with this swan in their neck. They can actually go down now just for a right and left heart cath and get the information, and the insurance says that's okay. The swan that we use here in the hospital is called a VIP swan, a very important port swan, and this is it right here. Swans are pretty synonymous through whoever makes them. What makes this swan special, and why we call it the VIP, is because this port, the VIP port, is just for infusions. You can infuse what your heart desires: blood, prayers, pressors, whatever you want to through it. And take note that it's a very small diameter, so if you're hoping to like slam some blood into somebody, it's probably not your best port, right? So talking about this honking one up here, this hooks into your monitor. This is the thermistor, or the one that tells you your temperature of your blood, and also the injectate that we shoot in through this CVP port right here, which sits in your right atrium. So we shoot dextrose in here, and this thermistor port measures the temperature of the dextrose as it goes into the CVP port. And then what happens is that dextrose goes through the RA, the RV, and into the PA port, which is this yellow port right here, and it measures a temperature and viscosity difference, which, you know, it does some funky mental math and it spits out our output and index. So again, our thermistor is our big port that sits just in the body. I think it's more so at the end of the PA port, I think is where that lives. And at where you inject the fluid, because it has to tell you, hey, what am I looking for at the beginning versus the end. The CVP port, which is the blue port, that sits in your RA. This gives you your CVP value. You can infuse through this. I don't recommend it. It should be the last place you want to infuse. The PA port, which is the most distal port on your swan, this is where we collect a mixed venous saturation, which we'll talk about later. You do not infuse through this port. This port right here is strictly for monitoring and just retrieving blood from. We talked about the VIP port, which is useful, and this port is our balloon. So this is a 1.5 cc balloon. It has a special syringe that hooks onto this, which allows us to inflate the balloon on the end of the swan, which helps with A, placement, but also B, allows us to obtain a pulmonary wedge pressure, which we'll talk about later. It's important to note that if you ever see a syringe on this, that it's not that 1.5 cc, more so the bigger, a 3 cc, a 5 cc, a 20 cc, a 50 cc if they hate their patient, you need to take that off immediately and just like dead end this port. Because what happens is if you inject too much air into this port, you can rupture that balloon, causing a reflux of blood through the swan, or worse, that balloon is wedged really far into someone's pulmonary artery and gets overextended and possibly ruptures someone's pulmonary artery, which is a surefire way for you to kill your patient. So these are just what these ports are for. This is just a little overview of, or just the verbiage of what the ports are for. Feel free to read through them. While we're talking about hemodynamics, let's talk about the normal values that we get in people. Now, again, normal is in quotation marks because our patients are not normal. They do not come to the intensive care unit in a normal state. We're seeing them on a terrible day, and we can just expect variance in what normal is. So some of the information that is vital for us to understand in hemodynamics is cardiac output and index. So this is all a measurement of how much blood per minute comes out of the heart. Now, what is the difference between cardiac output and index? Because they both measure the same thing. I will tell you that while everyone may have different cardiac outputs, everyone should have a similar cardiac index. And that's because indices take in account someone's body size. So where output just doesn't care how big or tall you are, cardiac index does care about your height and your weight. So it levels the playing field and is a more sensitive indicator of someone's true output from their heart. It's more so what we use in terms of talking about how functional someone's left ventricle is. CVP, we already know what this is. This is a measurement of preload or volume in the right side of your heart. If your CVP is 0, your volume down. If your CVP is 20, your volume up. Pulmonary artery pressure, this is both measurement of systolic and diastolic. This is measured within your pulmonary artery. So think of this as a blood pressure, so quarter over dime. So I will say that pulmonary artery systole, PAS, is a measurement of how much force that right ventricle has to generate to push blood into the pulmonary artery. Pulmonary diastole, PAD, is a stagnant measurement of fluid that is synonymous with how much volume is on the left side of your heart. Okay? So again, PAS is a measurement of how strong that right ventricle has to squeeze to push blood forward. Let's say you have someone with terrible pulmonary hypertension. This number is going to be high. It's going to be elevated because the pulmonary vascular resistance is high and that right ventricle has to generate pressure to overcome that. Think of someone in terrible heart failure that their left ventricle doesn't squeeze blood out effectively. Well, they have residual blood and they have volume overload inside of that left ventricle, so this PAD will be higher as well. Pulmonary wedge pressure, this is a measurement that we get whenever we inflate the balloon on the end of that swan. We get this stagnant blood flow measurement, and again, it is very synonymous and comparable to our PA diastolic pressure. We'll actually use our PA diastolic pressure as an alternative, than just wedging our patients every 2 hours. We will get this measurement whenever we put the swan in, and we'll look and compare how close they are, but it's just a volume measurement of our left ventricle. At PAD, pulmonary artery occlusion pressure, LVEDP, meaning left ventricular end diastolic pressure, all fancy words to say how much volume is in the left side of the heart. Think of it as a left-sided CVP. SVR, we talked about this earlier, systemic vascular resistance. This is the more so how much the left ventricle has to pump out against. So it has to generate at least this number to push blood forward. Remember, you also have a pulmonary vascular resistance where these numbers are going to be lower. And that's just because the left ventricle is more musculature and so is able to pump out against higher resistances than the right ventricle. SVO2 is a measure of efficiency. So it's a oxygen percentage measurement, which is drawn at the PA port, so right before the blood is reoxygenated. So what's happened is the blood has been ejected from the heart and it has taken the trip around the body. The tissues have plucked off as much oxygen as they need, and then what happens is we get this information back, and is how much oxygen is left in that red blood cell at the end of that cardiac cycle. Well, not cardiac cycle, but blood transport cycle, as it went from your left ventricle to your left great toe all the way back up to your pulmonary artery. The lower this number, the less efficient or more oxygen that your body has used, okay? We'll see this a lot in our heart failure patients where the body just is not, your tissues are ischemic. Your blood flow is very sluggish, so your tissues get more greedy and pluck off more oxygen. On the other side, we see like the 80-90%. We'll see this in someone with septic shock, especially if they're sick as snot. Like, why is someone's mixed venous in the 90s? Like, their body's being very efficient with septic shock and they're on all these pressors? Well, no. Just remember, septic shock is distributive, and that means that maybe the blood is not getting to the tissues for oxygen extraction to happen. So that's just a measurement of you could have a lot of ischemia going on. But yes, SVO2, just a measure of efficiency that the heart is generating. Just some simple complications. Well, I say simple, that some of these can kill you. That just exist with any time you insert anything into a patient, but let alone a advanced hemodynamic monitoring device, as it typically goes into their right ventricle, their pulmonary artery. It goes into their heart. It's intracardiac. It's dangerous. That's not a fun place to be, and a great place to have an oopsie if you have one. Arrhythmias is a big one, especially with swan insertions. That's just because the right ventricle is very irritable. And if you remember the trajectory of the swan, superior vena cava or inferior vena cava, right atrium, right ventricle. So you'll see some non-sustained VT and just some, as we're tickling that side of the heart. The best way to do is just get out of there. So you just keep advancing. Hopefully you get into the pulmonary artery or you come back and try again. We talked about the perforation of that little balloon causes a reflux of blood. We have to get rid of the swan or replace the swan because it's infection risk. Blood is pathogenic when it's stagnant. Lung infarction, so if we wedge somebody, remember that balloon is inflated in a little pulmonary artery branch. And what happens is blood just doesn't pass through there, and your lungs need blood too. So you cause a lung infarction where that lung no longer participates in gas exchange. PA rupture is the biggie here. That's one where you overinflate the balloon, and or the balloon is too far wedged, and the pulmonary artery cannot handle that little cc and a half. You have an 80% mortality if this happens because you need to be in an OR the day before. It's just a terrible thing to do. It's actually happened on the CICU one time, and it's a reason that nurses do not wedge patients in the CICU. refer to your unit in terms of who wedges, but in the CICU, we do not wedge our patients. Just some other common ones: infection, pneumothorax, air embolisms. I mean, don't go injecting air into your patient's IVs, let alone their central lines. Clots, bleeding, all the common ones are down at the bottom. These are the ones that are just like, God, ghastly, especially this one. This slide is more so just showing the anatomy of the heart itself, and more so the trajectory that I'm trying to get the pulmonary artery catheter into. So again, it either comes down your superior vena cava from your interjugulars or your subclavians, or inferiorly from your groin to your right atrium through your tricuspid valve, your right ventricle, pulmonic valve, and pulmonary artery. This is its tertiary location. Each area is associated with waveforms, and that's how we use to float this device. So it's put in at the bedside via NP, PA, MD, or in the cath lab or via interventionalist. You can use fluoroscopy to better discern where this is going. 90% of the time, waveforms are what we use. Again, each area has its own waveform: the right atrium, the right ventricle, the pulmonary artery, and a wedge. That is the four major types of waveforms that you need to be familiar with. So discussing these waveforms a little more, so you have the swan here. It's coming down. It honestly looks like it's either coming down someone's IJ or SVC or subclavian. Either way, it goes down the superior vena cava and enters into your right atrium. This is where we are going to get our CVP measurement. Again, CVP synonymous with right ventricular, or excuse me, right preload. So it's a measurement of the amount of preload, and it's kind of this bumpy, hilly, low pressure type reading that we get. As soon as you pass the tricuspid valve into the right ventricle, you see this huge spike in systolic pressure, and then this low diastolic pressure, which almost comes down to baseline or zero. And that's physiologically appropriate, because the right ventricle, what it's supposed to do is squeeze, generate a high systolic pressure to eject blood forward into the pulmonary arteries, and then relax. And then when it relaxes, it's got a voided space there because all the blood is hopefully forward, and it allows the blood from the right atrium to fill that void, which is what we have right here. So we have ventricular systole here, and then as the right ventricle relaxes, it creates almost this negative pressure to accept blood from the right atrium. Here we see passive filling of the ventricle, and then we have this huge repeat systolic spike. This is also where you're going to start to see the monitor have, the heart rate and rhythm have like spikes like this too, because you're going to have VTAC. Because remember, this right ventricle is extremely irritable, and the best thing we can do is just keep going and hopefully get it into the pulmonary artery. As we pass the pulmonic valve, you'll see this diastolic pressure. It steps up a little bit, and this is what we look for. We look for that diastolic step up, I think is what a lot of terms or books call it. And that's because with the pulmonic valve closing, there's always a column of blood inside the pulmonary artery. The pulmonary artery is never void of blood, so that's why we have that diastolic step up. You have a diacrotic notch that now appears, and that's our pulmonic valve opening and closing. And again, the PA systole is just the RV just pushing blood forward, and that synonymous pressure that's being transmitted through the fluid waves here that give us our PA systole and then our PA diastolic pressure. Remember what I said earlier is the PA diastolic can be used as a synonymous measurement to how much volume is in the left side of your heart. That's because your pulmonic valve is closed, and so all this fluid here is just being passively transmitted, and it's taking a reading, and it's just more so measurement of your left ventricular end diastolic volume. Again, I use the term left ventricle CVP rather. We get the same information as we continue to advance the swan. We wedge it in one of these tiny capillary beds. It wedges and essentially does the same thing as making an artificial valve here. You're just, again, looking forward for this left ventricular end diastolic volume, left ventricular CVP, what may have you. Your tertiary, or your final place that you should live and waveform that you should always see on your monitor, is your PA waveform. If you have ventricular waveform or if you have a wedge waveform, you have to call the provider. You can do some certain things like have the patient roll, have them cough, have them hold their breath. Ideally, it's something that you should call your provider about and tell them, hey, I have a RV waveform or I have a wedge waveform, and that's something your provider should come immediately to the bedside and fix. All right, let's practice naming some of these waveforms. So again, and this goes right in order, so there's really no tricking you during this. So this is the initial first waveform we have, and it's our RA-CVP waveform, right? It's kind of low pressure. You have, it kind of looks like rolling heels here. 2 to 6 is the magic number. Again, that's normal. We don't have normal patients, right? So if we have this number that's high, or RA pressure or CVP pressure that's high, again, it's a measurement of volume. If we have a CVP of 20, it means the person's hypervolemic, or there's a lot of volume on that right side. However, if that number's low, we can assume, hey, there's not a lot of volume there. That's that trauma patient that's left more blood on the outside than they have in, okay? So passing through the tricuspid valve, we get this new waveform. It's vastly different. It almost looks like VT. And this is our RV waveform. We have that huge RV systolic excursion. And then with RV relaxation, we have that near zeroed diastolic pressure to allow blood flow to easily pass from RA to RV to begin that cycle again. Remember that what you're seeing on your EKG in this area, you can see some non-sustained VT. The best way to remedy this is just get out of the RV as quick as possible. Pressures, again, you have a high RV systolic pressure, but that low diastolic pressure, and that's just physiologically correct in how that RV functions and operates. Again, reiterating that the RV is extremely irritable, and the best way to get rid of NSVT when passing a swan or something, or an intracardiac device, is simply get out of the RV. So question is, what happens if our systolic pressure is 50? So we talked about this a little bit earlier, that this number right here, our RV systolic pressure, is a measurement of how forceful that RV has to squeeze to push blood forward. Well, 50 is not a normal RV systolic pressure. So that means the RV is having to work harder to push blood forward. Things that could cause an elevated systolic pressure, RV systolic pressure, PA systolic pressure, again, you can use them both. They're both symbolic of the same thing. You can have someone with pulmonary hypertension, have someone with pulmonary edema, pneumonia, they're on a ventilator. All of these stress the right ventricle and cause it to work harder. For a short period of time, this can work. Your RV can pump out against this. However, the longer this goes on, the higher risk you can have of a failing right ventricle. And that's just because the muscle fibers are not meant to handle high pressures. Your RV is a low pressure system. That's what it's designed to handle, is low pressures. Okay, that's why we get a little squirrely whenever we want to put someone on the ventilator that has RV failure. Everyone sees a SAT of 88, 85, and the person's talking to them, and they've got to put them on a ventilator. Well, as soon as you put more pressure into the right ventricle and that RV is unable to pump blood forward, well, you have a dead patient. That's why it's always important for right heart failure patients. Intubation should be the last thing you want to do. Continuing on our journey, we finally reached the pulmonary artery. Okay, so we have that diastolic step up because we've passed the pulmonic valve, and there's no longer just a coming and going blood. It's just a stagnant volume of blood within that pulmonary artery, which is why we have the diastolic step up. We have the new dichrotic notch looking thing here, which is just the pulmonic valve opening and closing. The RV systolic function, again, now turns into our PA systolic. Okay, just our diastolic pressures have changed. It hopefully looks like a very nice arterial line tracing. Hopefully, it doesn't always. Pressure-wise, again, quarter over dime is normal. Remember, your PA systolic pressures is the amount of of exertion that RV has to exert to push blood forward. The higher that number, the harder the RV is having to work. PA diastolic is the residual amount of blood in the left side of your heart. So it's a a measured value of how much volume is at the end of diastole in the left side of your heart. Think of it as the left ventricular CVP rather. Okay, the higher the number, that means there's not blood that's being ejected from the LV. That blood is being retained inside of that cavity, which is not what you want, right? You want your blood to be ejected because that's how we live, is we eject blood out and get it to our vital organs. Okay, so we keep advancing because we want to get the pulmonary wedge pressure whenever we put one of these in. So the pulmonary wedge pressure is just when that balloon wedges itself in one of those capillary beds, and it gives us this very dampened waveform. Okay, we go from this PA waveform to this more dampened waveform. And again, this is just a synonymous. You could use this in terms of your PAD versus your wedge pressure. They're in terms sometimes very similar, like maybe 1 to 2 points off from each other. This is just the measurement of that left ventricular CVP like we talked about before. Again, you do not want to leave your patient in this. This can cause a lung infarction because there's no blood flow getting downstream here because you've created an occlusion. So you should always want to make sure that your patient has the PA waveform as their tertiary waveform on their screen. All right, just a special slide to talk about the actual PA systolic and the PA diastolic, just to reiterate that more, just because it's kind of hard to wrap your brain around. It takes time for you to kind of grasp and say, oh yeah, that's what this measures. So again, PA systolic, here's the physiology behind it. And again, the sensor's right here on the end of this balloon here, and it's a measurement of how much force this right ventricle has to generate to push blood forward. So PA systolic pressures do not care about the left side of your heart. Where's my little thing at? All right, well, there we go. So PA systolic pressures do not care about the left side of your heart whatsoever. It is a measurement of how much force this right ventricle has to generate to push blood forward. We talked about pathophysiology, which causes that. Fibrosis, pneumonia, pulmonary hypertension, mechanical ventilation. That is not a normal way to breathe, and there's excess pressure exerted within the lungs, which is reverberated down to your right ventricle and causes stress. Okay, so it requires more oomph for your right ventricle to squeeze, thus a higher PA systolic pressure needs to be generated. Okay, so in PA diastole, you're now more so worried about the left side of your heart. So whenever PA diastole happens, you have the pulmonic valve which is shut. Okay, and so I've already said that PA diastole and our wedge pressure can be used interchangeably if they are similar. There are instances where they're not similar and you can't rely on that, but about 80% of the time you can bet that your PA diastolic pressure and your wedge pressure are very similar and can be used interchangeably. Okay, so remember your PAD is when this pulmonic valve closes and it creates that evaluation of the left side of your heart. Remember your left ventricular CVP. When you inflate the balloon and create a wedge, you're basically just creating a false valve right there. It's just further down the line here. And again, this is all looking at the volume on the left side of your heart. So again, the higher the volume means that this left ventricle is retaining blood. And so blood that is not escaping from your aorta and going to the body is just, it's a sign of failing left ventricle, okay? Because the whole point of the left ventricle is to squeeze blood forward. So either something is obstructing, the left ventricle is not strong enough to handle it. Either way, if you have residual left ventricular volume, you can expect problems to occur. Pulmonary edema, as this volume backs back up through your left atrium into your pulmonary vasculature and causes pulmonary edema. So it's a measurement of, again, left ventricular end diastolic volume or volume on the left side of your heart. Okay, We talked about this a little earlier, the SVO2 or mixed venous value. This is the blood measurement that we get from the pulmonary artery catheter at the PA port. So the most distal port of that catheter right before the blood is reoxygenated by the lungs. And I told you it was a measurement of efficiency. Here's a little demonstration that, hey, we have 4 hemoglobin cell, or on the red blood cell, we have 4 hemoglobins with 4 binding sites, right? So it's 100% when it comes out of the lungs. It's freshly oxygenated. We have a normal cardiac output here. It goes through. Our tissue demand is very low because, hey, we have a normal cardiac output. There's a continuous stream of blood that goes down and feeds the tissues. The tissues aren't ischemic. We're also maybe not doing something very strenuous that requires extra oxygen, so it extracts just 25%. So the time this gets back up to our pulmonary artery and we take that sample, our mixed venous may be 70-75%, which is quote unquote normal. However, we have someone that has poor cardiac output. So someone that's, let's say, a heart failure patient whose cardiac output goes from an Amtrak to a locomotive. So it's a slow transition from left ventricle to left toe back to the lungs, okay? So our tissues have more demand because there's less time that fresh oxygenated blood is being seen, and they could start to do some anaerobic, metabolism, and so they need more oxygen. That's, we do not operate on anaerobic metabolism. It's not a great thing to operate on. That's how we build lactate and die. So tissue demand goes up, so it extracts more oxygen, and so when it returns back to the pulmonary artery, we could be looking at a PA sat. I've seen them as low as 20, and I've seen them as mild as in the 50s. And so we have to figure out, how do we improve cardiac output? Remember, in distributive shock sepsis, for probably our number one example, that tissue demand is high. However, let's say that you are so distributed out that the tissues are not connecting or communicating with the actual oxygen delivery system. So we'll have a falsely elevated SVO2 in these distributive/septic patients because oxygen is just not being exchanged with our tissues. They're ischemic, they're just not able to pluck off this oxygen, thus we get SVO2s in the 80s and 90s in the sickest not patient, which we know is just not, that's not true. Okay, so talking about now, more so looking at shock profiles, this was a thing that we added, or I added rather, to talk about the different types of shock and what does it look like on our hemodynamics. So hypovolemic shock is our starting point. Ooh, excuse me. Hypovolemic shock is, you have your trauma patient, and like I said, I love using the analogy, you left more blood on the sidewalk than you did in the patient. That's just not the things you could happen though. Let's say we diurese the fool out of somebody. They have DI and they just peed all of their fluid out. They've been nauseous, they've been vomiting, they've either thrown up or diarrheaed all their blood, or not blood, Lord, I hope not, fluid out of their body. It's basically a total loss of fluid. Total means that it is gone from your body, that it's not displaced in your leg, it's not displaced in your abdomen. The fluid is gone. It has exited your body. So what does your patient look like? So your heart rate is going to be high, right? Because that's what happens whenever, you try to compensate. Your body tries to keep a sense of normalcy and, change variables that it can in your body. So whenever you have a depletion or the amount of volume in your body is low, it's going to jack up your heart rate. What about your blood pressure? If you're in shock, your blood pressure is going to be low. Okay, your body has tried to compensate, but unfortunately, if there's not circulating volume, you're not going to have a blood pressure. Same thing with your CVP. Remember, this is a measurement of the volume returning to the right side of your heart. Well, if the volume's not in the right side of your heart, it's on the asphalt. So the CVP is going to be low. What about your wedge pressure? Wedge pressure, again, is a measurement of the amount of volume in the left side of your heart. Well, if you don't have volume in the right side, you're not going to have volume in the left. The SVR, what do you think this is going to be? So, like I said, your body tries to compensate. And the way your body compensates is it jacks up your heart rate and it says, ooh, squeeze on the pipes. So it tries to artificially keep a normalcy of your blood pressure by increasing your SVR. This is what our body does innately. It increases your heart rate and it increases your SVR in terms to generate or keep a normal blood pressure. Okay, so your SVR is going to be high. So how do we fix this? Well, this is pretty simple. We give them volume. We give them fluid. We give them blood. We replete what they are missing intravascularly, which is volume. Distributive shock. This is we talk about this. People like to say septic shock. Well, sepsis is not a type of shock. It's a further subset of distributive shock. Anaphylaxis and neurogenic all fit into this distributive picture. And we talk about neurogenic a little bit I think on the next slide because it's very scary. It's very special. Volume displacement is the biggest thing in distributive shock, where hypovolemic was an absolute loss of volume, meaning that the volume has left the body. Distributive shock is if, I like to use septic because that's a lot of the patients that we see in the ICU, is where you have just vasodilated out. So your vasculature has gotten huge, and so the fluid has been able to escape out of think of them like pores outside of your vasculature into your subcutaneous tissue or whatnot, or that's just pulled in the bottom and deep into areas of your body, and it's not able to make it back to your right heart to restart that cardiac cycle again. So it's just a relative displacement of fluid, meaning the fluid is somewhere it's not supposed to be. So what is our heart rate doing? Well, like I said, you try to compensate. So your heart rate's going to be high. CVP, remember you're vasodilated out, meaning that the fluid has just seeped out of your vasculature into your little tissues, or the blood has pooled in your feet. CVP is measured at your right heart, so your CVP is going to be low as well. SVR, remember our compensation, heart rate goes up, SVR goes up as well. Okay, that's initial. I will say that this is where it gets kind of tricky, and if you remember the whole physiology behind septic shock is your body tries to compensate. It tries very hard in the beginning. And that's where you have these septic patients that, they come in and they're not in shock yet, they're just septic. Their heart rate will be high and their blood pressure will be hanging on. However, as they progress into shock, they can't compensate anymore and that SVR number goes low. So initially that SVR is high normal, and then as the shock progresses, that SVR drops. I'm talking like 400, 600, and that just shows us how dilated our vasculature is. Cardiac output, again, initially it's going to be normal to high because our body's able to compensate. However, as time goes, and this goes along with that dilatation of our vasculature, well, if you don't have blood in the right side of your heart, you're not going to have blood in the left side of your heart either. So our cardiac output and index drops the longer this septic process or distributed process goes on, rather. So how do we fix this? Well, in the terms of the whole septic shock picture, well, we volume resuscitate them. Remember, we have to give some people some volume back. Staple is antibiotics. Oh, wow, no, excuse me. Antibiotics, antimicrobial coverage. And then if they're still hypotensive, we do vasopressors. So we support them with Levophed, vasopressin, what may have you, to generate a normal blood pressure, a normal perfusion pressure. So neurogenic shock, this is a crazy type of shock. It's actually probably scary to me. Going through the NSICU and seeing some of these patients go through neurogenic shock, I'm like, ooh, don't want this. This is essentially wherever you have a disrupted roadway. So think of your brain as like the great decision maker. It tells your body what to do, and then you have the train track or the road, which is your spinal cord, which is able to send information from the brain, and your periphery is able to take information and send it back up to the brain. The best thing I like to use is people that have either you know total or subtotal spinal cord injuries, and they have to pee. Their bladder gets really full, and their body is just sending um, messages from the bladder to the brain because that's how we do. That's how our body talks to one another, and how we say, "Ooh, I have to go to the bathroom." Is our brain doesn't generate that sensation, our bladder does. Our muscles stretch, the neurons send that information through nerves, through like our through up our spinal cord to our brain, and our brain interprets that as I need to go to the bathroom, I need to pee. Well, what happens is if there is a sub or total break in that road, those that information can't get to the brain, and the brain can't interpret that. So your body essentially goes into this type of sensory overload, and we are very dramatic beings, and this is what happens is your body says, well, I guess I'm going to die since you're not going to listen to me. So what happens is your heart rate, you become bradycardic. Your blood pressure, your blood pressure can be really low, and your SVR can also be really low as well. It's very scary, and the best way to relieve this type or this presentation that your patient's going through is actually to relieve the process. So you drain the bladder. That's not the only way. Some people, whenever they have to poop, these people can't. They don't have the sensation to go defecate. They have to use digital stimulation to help them poop, and that's another way that people can experience neurogenic shock. Feet injuries are a big one too, because if they can't feel the sensation, like they've got an ulcer or they've got a sore on the bottom of their foot, just that continued stimulation and ignored stimulation from the brain can cause someone to go into neurogenic shock. Cardiogenic shock. This is my bread and butter. So, cardiogenic shock is a pump issue itself, meaning that it's the muscular part of the heart which is in trouble. I'm not talking about the valves. I'm not talking about, um, you know, anything else. I'm talking about, hey, this is a heart muscle problem, right? So the body attempts to compensate for a weak heart. It'll say, okay, well, just like everything else, it's going to jack up your heart rate and it's going to squeeze and your increase your SVR. Well, a weak heart hates two things. It hates a lot of fluid and it hates high afterload. That's because it cannot pump out against a high afterload. So this patient right here, the body, starts to go into shock and the body tries to kill itself. The heart rate, not so much worried with. Yeah, you don't need to let your heart be 160, but at some point, a little bit of a tachycardic patient with cardiogenic shock is a good thing. But the SVR is what's really killer in this situation because that just further exacerbates the inability of that LV to pump out blood. Okay, so not only do you get a decreased blood pressure, you get tissue ischemia. You get this patient that starts to look, they start picking, they start pulling, they get more confused, and then it is just a downhill slope to the morgue, essentially. So, how do we fix this patient? So, if we, the biggest thing is I can put them on an inotrope. I can put them on dobutamine or milrinone. I'd probably pick dobutamine if the patient looked absolutely terrible. My goal is to increase the amount of blood that's coming out of the LV to perfuse tissues. If medicine isn't enough to fix someone's ischemia caused by their heart, then they go on mechanical support. They get a balloon pump, they get an Impella, they can go on ECMO. Cardiogenic shock is very scary because it not only affects, well, I guess all these are very scary, but it affects them very quickly, and it's a central pump problem that if you don't jump on and you don't fix quickly, then the person, well, they end up right here, very stable, very very dead. Obstructive shock. So this is cool. So this is one that we typically don't think about. So obstructive shock is the muscle of the heart, the lungs, the actual functionality of them is a-okay. There is nothing wrong with it. The problem is the obstruction of blood flow through our natural structures. So it's not a pump issue, it's a mechanical obstruction issues. This includes vascular things too. I talked earlier about someone with aortic stenosis. That is an obstructive shock process. If that valve is so tight that blood cannot shoot out of the left ventricle through that tight aortic valve, then yeah, it's a primarily obstructive shock process. That doesn't mean you can't have heart failure from a bum aortic valve, but realistically, what came first, chicken or egg? The obstructive process in that situation. Pulmonary embolisms, another great example. You got a blood clot in someone's pulmonary artery. That RV, again, we talked about that increases RV workload and the amount of pressure that RV has to pump out against, and that RV fails. That is an obstructive shock process. Pericardial effusion. So you have someone with cardiac tamponade. There's a amount of fluid in that pericardium, and that heart just cannot contract and relax enough to pump blood forward. It's not a muscle problem, it's something that's obstructing the normal functionality of the heart. Tension pneumothorax, you have an increasing amount of interthoracic pressure and it pushes over on your major vessels in your heart, causing an obstructive shock process. Again, nothing is physically wrong with your structures in your body, the heart, the lungs, etc. It is something else that's obstructing the natural process of this. So, how do we fix it? So, you fix the problem. Aortic stenosis, you get a balloon angioplasty or a TAVR. PE, you get lytics, or you go and you get a embolectomy. Tamponade, you get that bad boy drained. Tension pneumothorax, you get a needle decompression and a chest tube. And then you will be amazed on how sick these patients look in terms of hypotensive and just shocky. You resolve their obstructive process and they look great. And they have never been more scared in their life because they were at death's door and then you did an intervention and now they're a lot better. These are the most probably rewarding things is, we've had people with cardiac tamponade before. We stuck a needle in their chest and they've come off all their vasopressors and they're eating lunch, um, you know, just 4 or so hours after coming into the hospital. Still got to figure out why they developed the tamponade, but it's very rewarding whenever you get a sick, sick, sick patient and then you can make them better pretty quickly. This is just my little pitch on, keeping things tight, neat, and orderly. So you, like I said, you are the intensive care nurse, and I know you have busy days and you have busy assignments, and things cannot be pristine, and things may be a little bit messy and it's chaotic. The key is it needs to be controlled chaos, right? So take at it from a family's point of view, and I know, this. I've done it. We've been at bedside together. You get difficult family members, and you're just like, God, this family member is just riding my case all day about poor little Mima, and she's just being, essentially just hovering about her. Well, if I were to walk in your room and I saw this rat's nest of cords and cables and IV tubing, I'd be like, you don't know what you're doing either. So this is just more so a little caveat to be like, be a master of your craft. Take the time, fix the cables, fix the cords. People, well, they get up, they move around. Well, guess what? You're going to do it for 12 hours, so you need to just keep doing it anyway. It makes you look like a good nurse, and it makes the families at ease because they think you know what you're doing and that you can look after their loved one. I do walk around the unit sometimes just if our people get floated, just to kind of check on everyone, and I try to at least be present and offer people to come to the CICU and see swans and whatnot. So if I ever go to your room and I see this, and we've had this talk, and you're outside reading Nicholas Sparks' book or doing a Sudoku, then I'm going to give you this face right here because I told you so. Okay. All right. So let's talk about this patient. So this is a real life scenario of a patient I had in the CICU, and let's just talk about how they're doing hemodynamically. So I didn't capture the heart rate, but it's down here. This is their pulse rate off the arterial line. So their heart rate's in the 140, so they're tachycardic. We can see their arterial pressure here is 101 over 43, and their PAP pressure is 83 over 37. Look how close these numbers are together. This is not a good thing, okay? When your intracardiac pressures are almost synonymous with your systemic pressures, that means there's almost a stasis or a stagnant blood flow. Blood flow from the left ventricle to the body, it ain't happening, or it ain't happening much in this case. Okay? I can tell you that this patient was on the ventilator and had every pressor in the book going to them, um, and that they had pulmonary hypertension, but they also had aortic stenosis. So, taking this from a pulmonary hypertension standpoint and on the ventilator, remember those are right sided lung problems. That's going to increase the amount of workload that RV has to squeeze and has to, overcome work for. And so we see an increase in the amount of RV or PA systolic pressure that has to generate. This is an astronomical amount that RV has to pump out against. Your RV is going to fail if this continues. I also said that this person had pretty terrible aortic stenosis, which is a obstructive process. And so what it does is blood keeps coming from the right side to the left side. That doesn't stop. That's how we live. Blood comes to the right, it goes to the left. Well, that cap or that stenotic valve on that aortic valve is not letting blood escape the heart. So we have an increased LVEDP. There is more blood in that heart at the end of diastole than we know what to do with. So we see that at our PA diastolic pressure, which is a synonymous left ventricular end diastolic pressure too. So these are not optimal numbers. I can tell you that this patient unfortunately passed away. And here's just a kind of thing. They had severe pulmonary hypertension and aortic stenosis, and we talked about how it, correlates with these. But this patient did unfortunately pass away. Okay, so let's talk about some questions. So I walk into your room, or you walk into your room, and you see this on your monitor. Your patient has a swan. We put it in a day ago, and this is what you see. So you check your swan, and whenever it was put in, it was at a depth of 65. You look, it's still at, you know, 65, 66, 67, wherever, somewhere around in that number, in that range. Well, you should recognize this as a wedge waveform, okay? The swans, they're plastic. They're a type of plastic. Just know that, whenever you put these in the body and they sit for a little while, they can elongate and they can auto wedge themselves. So just because the balloon's not inflated doesn't mean that this can't happen on its own. Now, the way you troubleshoot this is you make sure there's no air in the balloon. You try to take air out of the end of that balloon as best as you can. You can have the patient roll, you can have the patient cough. But if all else fails and you continue to have this wedged waveform, you need to be putting in a call to your provider and tell them that it's wedged because it has to be this. The swan itself has to be retracted. I would consider this a medical emergency because if you were to continue to leave the person in the wedge waveform, remember you can infarct a piece of the lung, which is not ideal. Okay, little multiple choice here. So you have a patient that has a blood pressure and all the hemodynamics listed at the left of your screen. Um, looking kind of there, your heart rate's high, your SVR is high, so the body's trying to compensate. So they're in shock. Their CVP is unimpressive. The PAP numbers, they look pretty normal. Yeah, quarter over dime, they look pretty normal. That output's low though. I can give you that. So let's talk about each option. So are we going to start dopamine on this patient? So 5 mics per kg per minute. Well, that doesn't really make sense, right? Because look at your heart rate already. It's nearing 130, and what you're going to do? You're going to hope to increase your blood pressure and shoot yourself in the foot by increasing your heart rate. That doesn't really make sense. So debutamine's going off the fact that our output's low. Well, first off, debutamine of 10 is crazy. Like I said, I've never prescribed anything over 7.5 of debutamine, and it's just not a smart dose, and it's not the phenotype of shock that you're going in. You don't know if this person's in cardiogenic shock or not. You need to look elsewhere. Going down to the bottom, nipride. So if you are unfamiliar with nipride, it is a very potent vasoarterial dilator. It's more potent than nitroglycerin. So again, you stick someone on nipride, especially at 1, and it's going to make your blood pressure even lower than it is. So that's not a smart option either. So the correct answer is they're hypovolemic. They're in hypovolemic shock, and you need to give them volume. So we're going to get started by saying, hey, let's give them a 500 cc fluid bolus. Hopefully that increases our blood pressure, and it decreases our heart rate and causes our SVR to decrease too as we correct that shock process. Okay. Next question is we have the data to the left again. So you have a blood pressure that's semi-normal. Your CVP is 3. Your PAP number is 44 over 24. That's pretty impressive. Remember, quarter over dime. Your wedge pressure is 22. That's pretty significant too. Remember, 8 to 10 is where you should live. Your SVR is elevated as well. Your index is low, and your SVO2, your mixed venous, is also low. So not very efficient. You got a lot of volume on the left side of your heart. So are you hypovolemic? Well, someone's probably going to look here at the CVP and be like, heck yeah, you are. Let's give them fluid. Well, the fluid's not in the right side of your heart. It's all on the left. Look here. So you got a PAD of 24. You got a wedge pressure of 22. You got fluid. It's just not getting outside. It's not escaping your body. That kind of gave it away, didn't it? So you're an LV failure at this point. And you can say that by multiple points. Again, you've got an overwhelming amount of fluid in the left side of your heart with these two numbers. And look at your indice. It's also low, and your measurement of how efficient your heart's being is low too. Severe sepsis. So like I said before, in early sepsis, your SVR can be high, it can be normal. However, as if you're in severe sepsis, you're in that progressed form of shock, that SVR is going to be low. So more like 600, not 1600. And I didn't give you anything to say we're in ARBs. I have given you no respiratory information here whatsoever. Okay. So you have this patient, and this is without a swan, where their MAP is now 58, where 2 hours ago it was 70. They're tachycardic, they're febrile, they're anuric, or excuse me, olguric, Lord. Their skin is warm and dry, and they have a leukocytosis going on. So you can think, hey, all right, well, they got a fever, they have a white count, they're warm and dry, they don't have any urine, and now they're getting hypotensive. What type of shock do you think they're in? Well, they're getting to a distributive shock, more so a septic shock picture from this. So I've already said, remember that in early sepsis, your SVR, which is what we're questioning here, is normal to, can be a little bit elevated, but as our shock progresses, that SVR drops off. And SVR, especially low SVR, is an indicator of severe sepsis. So in this case, we would go with the lowest SVR, which is the 550 dynes. Okay. Things keep getting worse. So you have this. So which patient could result in an elevated pulmonary artery systolic pressure, but a normal pulmonary capillary wedge pressure? So what I'm asking in this question is, what disease process is a primary right-sided problem? Okay. So what is a primary right-sided problem? Let's go from the bottom because this is the easiest one to eliminate. Constrictive pericarditis. Well, this can be an obstructive shock process. However, it's going to affect both your wedge and your PA systolic pressure because what happens is your heart pericardium is constrictive and constricting everything within your LV, your RV, your great vessels, and it makes all the pressures similar. So this is more so a whole heart problem, not just a right-sided problem, which is what I'm asking. Another easy eliminator is LV failure. Well, here I'm asking specifically, what is a right-sided problem? An elevated PA systolic, remember, is how much that right side has to squeeze to eject blood forward. Again, this is looking all at the right side, PA systolic. And a normal pulmonary wedge pressure is not indicative of LV failure. Aha, pulmonary edema, that's it. It's not. Pulmonary edema, well, it can and will cause an elevated PA systolic pressure because remember there's edema in those capillary beds, which cause that RV to have to work harder. Pulmonary edema is not a sole right-sided heart problem. It actually originates from a failing left-sided problem. If you have pulmonary edema, you have increased volume inside the left side of that heart, which would not equate to a normal pulmonary wedge pressure. It would actually be an elevated wedge pressure. So the answer is pulmonary hypertension. This is a strict on. This can be an idiopathic and or a pure right-sided problem, which causes pulmonary vasoconstriction and increased pulmonary vascular resistance, which makes that right-sided work immensely harder than it should and elevates your pulmonary systolic pressures. Okay, so you have this patient who has ST elevation in 2-3 and AVF. And for my cardiac people, this is a inferior STEMI. That's right. So you have elevation in 2-3 AVF, and you have reciprocal changes in 1 in AVL. Okay? You have peak T waves and JVD. You have nitroglycerin going. You have dobutamine going at an obscene amount. Your blood pressure's okay-ish. Your heart rate's high. Your CVP is getting on up there. Your wedge pressure's okay. It's 5. Your pulmonary artery pressures, your PA systolic and your diastolic are okay too. Your index though is starting to look a little measly. So what do you want to do? So let's start here. So are we going to increase our dobutamine to 20? Well, this is a stupid option. This is dumb. So this would not make sense at all, and it's trying to compensate for this 1.9 liters per minute on your cardiac index. This does not make any sense at all. And plus, with dobutamine, I'm not really keen on using that um, for ischemic patients anyway, especially acute ischemia. Wouldn't be too keen on that. Milrinone, again, trying to compensate for this 1.5 cardiac index. Well, sure, if you want to try to fix a number without fixing a problem, I guess shove an inotrope on there. However, remember that milrinone takes about 4 hours for it to work. So you're going to see this patient, quote unquote, get better in 4 hours, which is not another great answer choice. Let's drop down to D, kind of gives you the answer, but start dopamine at 10, which is more of that alpha effect to increase blood pressure. Well, it, again, not really going to fix the problem. You're also probably going to make your heart rate a little bit worse too, because while you have primarily alpha, you do get some beta activation, which is probably going to make things a little bit worse. The right answer is actually decrease your nitroglycerin or discontinue your nitroglycerin and give them a little bit of volume. And that's because somebody that's having a inferior STEMI, that is a right-sided myocardial infarction. And right-sided MIs are preload dependent. So meaning that it needs a little bit of volume to be able to passively pump fluid or passively allow fluid to go from right side to the left side. Nitroglycerin, I know we have all been lied to as nurses to say, oh, that's for chest pain. It dilates coronary arteries and it makes your chest pain go away. That's not true. What nitroglycerin actually does is it makes your IVC bigger and it allows less fluid to return back to your heart. Well, that allows your heart to be a little bit more efficient because during this time you're probably panicking because your chest hurts. So you have more fluid coming back to your heart and it's causing stretch in those myocytes or the cardiac muscle because you just are pouring blood into that RA and RV because your fight or flight's activated. Well, whenever you have increased volume and fluid return and stretch in those myocardial muscle fibers, it causes or you have to use more oxygen to cause myocardial contraction. And the whole point of having someone or the whole point of treating someone with an MI is to conserve oxygen. So the way we do that is we give them nitroglycerin. It causes a decrease in the amount of fluid return to the heart, which in turn causes a reduction in the amount of oxygen that we have to use to allow for contraction. The 500 cc's or mils of fluid, again, is all based on the fact that this is a right-sided MI, and they're very volume sensitive. You can't drop their preload too much because, again, the right side of their heart is undergoing an infarction, so the muscle may not move like normal. So you have to give a little bit of volume there to ensure that whatever contractility that heart's doing, you actually have some forward flow of blood. Okay? Well, that's the end of the lecture. I hope you really enjoyed it. Again, it's something that I enjoy doing. I love talking about. Again, I'm sorry that I'm not there in person to talk about these things because that's truly how I enjoy teaching this class. Just because you were able to ask me questions and we're able to better clarify things. And plus, I just like being around people and talking to people and seeing how the light bulb go off and be like, oh, well, this is I now understand this. If there's anything that needs to be different in these presentations, I always, always, always say just tell the instruction coordinators. They're able to relay that information to me, and I'm able to alter this class. It's all in what you need. It's not what I need. It's what you need as nurses. So I hope you take something away from this class and you're able to apply it to practice and you become fantastic critical care nurses. And I appreciate you listening for this hour and a half. I know you've listened to me drone on, but as always, I implore you or invite you over to the CICU. If you don't get the opportunity to see a pulmonary artery catheter during your orientation, well, come on over, and I'll be more than happy to walk you through and talk about some of the variables that we talked about in this lecture. But until next time.